I'll try as we go through to focus on things that are new or are changing, because I think that's the most interesting for all of us. So just a brief update on epidemiology. There's a few gray heads in the room that were probably in practice in 1981, as was I, when the first AIDS cases were reported. It doesn't really seem that long ago, but now, of course, we're training residents here who were, in kindergarten or something. So it's changed the landscape, I think, in many ways of most aspects of medicine that we practice. HIV is definitely here to stay. In 25 years, it's successfully traveled the globe. These are WHO data from estimates from the end of 2005, fairly self-explanatory. Probably about 1 million people in North America with HIV and AIDS, and sub-Saharan Africa, as we all know, devastated with an enormous problem. But it's basically gone everywhere. These are slightly different metrics in terms of outlining the inequity in income, or it's a disease of poverty basically. So poor countries are very heavily affected. A lot of children. Globally, it's 50-50 men and women. That's not the same as the demographics we see in this country, and it's one of the leading causes of death worldwide from infection, up there with TB and infectious diarrhea. So now this is switching to US data from CDC. These are reported cases of HIV and AIDS for the last time period for which data are available, and just give you a little snapshot of how the epidemic is changing in terms of race, ethnicity. Again, nothing terribly new, still overrepresented in the black minority population. And these are, percent of cases, so obviously the makeup of the general population informs this too, but clearly more than 50% black is way more than the average population. These are by risk category, or how people got infected with HIV. In this country, we still see men having sex with men as the most predominant risk category. That's not true globally, where heterosexual transmission is the most common. A bit less here, maybe a slight decrease in injection drug use over the last 3 years. And then this is just to give you an idea of how prevalence varies across some states. These are also illustrates the difference between epidemiologic data about HIV infection, which is not reportable at every state, including places like California, where they have tons of patients. AIDS is reportable in all 50 states and has been since 1981, but HIV infection is not, and it depends on where you live as to what the reporting requirements are, and this gives you a sort of an idea. It's mostly a coastal phenomenon, with the middle of the country having relatively lower prevalence, although of course not none. And then by gender, there's slightly different characteristics amongst men and women. Men have predominantly male-to-male sexual contact as their risk category, and women, it's pretty much all heterosexual, with a chunk of women who have problems with intravenous drug use. So that's sort of a snapshot of where we are with epidemiology. There's not really a lot new to say about pathogenesis of HIV infection. That's all been pretty well worked out. We know now it's a virus. It came from chimpanzees. There hasn't been a lot of very exciting new pathogenesis information, just small incremental improvements. This is the sort of disease spectrum that is the most useful way to, I think, categorize patients when you're following them clinically. This is how it looks schematically over time, from infection to the onset of symptoms, AIDS defining illness, and death. So looking at CD4 counts on the y-axis here, the average being about 1,000, range in most lab for normal CD4 positive T cells is 300 to 2,000 roughly, depending on the state of the immune system. But using 1,000 as an average, an untreated person will lose 90 to 100 cells per year, so 10 years later they're out, and that's when they get in trouble. There's a sort of initial dip with acute infection, and then some small recovery, which over time is overwhelmed by the relentless virus replication. Symptoms generally starting at around 400 CD4 cells, where you start to see some thrush, fatigue, TB then. But the major opportunistic disease is occurring at this part of the disease spectrum. after development of AIDS, and the life expectancy then being about 2 years. Now, this is, of course, all absent treatment. And so the availability of drugs that actually work has really changed the landscape as far as that's concerned. And people often ask me, what's the life expectancy now of someone on combination antiretroviral therapy? And of course, the short answer is nobody knows, because we haven't got there yet. But the longer answer I usually tell patients and so on is that to consider it more like another serious but manageable chronic disease. And I use diabetes as an example of something where if people take care of themselves and eat right and take their medicine and don't do anything stupid, that they'll probably be quite likely to live to be 60, maybe 70, 80 would be optimistic. And I think HIV disease probably falls into that category now. This cartoon is probably familiar to most of you. It's essentially a CD4 positive T cell here with the receptor to which the virus attaches and then is uncoated, integrated into the nucleus. New viral proteins are made, a new virion buds off to infect other cells. This is the general life cycle of HIV infection. So what's a little bit new about this is the targets that we have now to interrupt this process with medicines. So the first ones, it's probably a bit hard to read, is from here. Reverse transcriptase inhibitors, this is your AZT, DDI, 3TC group, the first drugs to be developed, still commonly used as part of a combination. Once combined with protease inhibitors, we saw dramatic improvements in treatment outcomes. We now have the first available attachment inhibitors. This is an expensive and difficult drug that I'll discuss more briefly, but it's another sort of tool in the armamentarium. In development are integrase inhibitors, which look extremely promising. There's been clinical trials of those showing very good promise, particularly in patients with limited options and drug-resistant virus. There are co-receptor inhibitors in clinical trials, including at this institution. These are drugs that inhibit these co-receptors, which essentially, help the virus get into the cell. So inhibiting that may also slow things down. And then more investigational yet, but maybe another group would be maturation inhibitors. And again, there are clinical trials ongoing, early clinical trials of these drugs. So a lot more options considering, we started in 81 and first drug available in the late 80s. And there's really been an explosion of research both from pharmaceutical companies and NIH and others to develop compounds with activity against HIV. So goals of therapy, this is, I won't read all of this slide. I think it's fairly self-explanatory now that we worked out virus replication was causing the problem, and that's continuous throughout the course of disease. Slowing that down, stopping it altogether is the goal. A cure is still not something that we in the HIV business talk about. We talk about as the C word that we don't actually say, but that's not entirely off the table, but there's no indication that any of the currently or future agents are going to be actually able to permit that. It's still going to be a question of suppression and management rather than eradicating a virus, and these are the tools with which we used to try to get there. Generally speaking, the accepted definition of success rather than improved life expectancy or lack of infection is a surrogate marker, which of course you can achieve more quickly, which is undetectable HIV RNA at the most sensitive assay available, which is less than 50 copies per mil. That's kind of the gold standard of successful treatment, but there are other issues too. So the management of patients with HIV disease remains, I think, complicated, and it's much easier to do if you have help. And I know that's easy for me to say, and many of you probably don't have hot and cold running case managers and nurse coordinators and all the rest of it, but it does go much better if you can have access at least to some kind of multidisciplinary team, because there are always social issues and money issues and all the rest of it, because even in this country, again, it's a disease of poverty, and people living in poverty have many more of these issues. They're mentally ill, more likely, substance abuse, et cetera, et cetera. So I'm fortunate to have a team like that here, although I don't just get given them, by the hospital. I have to raise money to keep them and so forth, and so it's always a challenge. it's now become really much more of a specialized disease, and there's a fair amount of data to support the fact that providers that are experienced in caring for people with HIV will get better outcomes in terms of how patients are managed. So it's not really the kind of thing you want to dabble in, but of course that's not always an option. You know, if you're a rural provider and someone shows up on your doorstep, you have to do something with them. So essentially the management is along the general lines of anyone with a chronic disease, you know, the basic lab tests. The default is to see people about every 3 to 4 months and make sure their CD4 count and virus load are up to date. These are the vaccinations that are recommended for people with HIV disease according to the usual kind of guidelines. And then the new thing that will be coming later this summer is a recommendation that new patients should have testing for resistance to HIV. And this is because of increasing prevalence of drug-resistant HIV in the community, which is then transmitted to newly diagnosed patients. So some cities in this country have 15 to 20% of their newly infected, newly diagnosed patients have drug-resistant virus. And so that's not something we see here at my clinic, but at the same time, there will be a kind of global recommendation that everyone should have a resistance test at baseline, which of course is another expensive thing that we have to do, but it does make a difference in terms of outcome. So the big question about when do you start therapy, like many questions in medicine, the answer is multifactorial. There are obviously the regular biological indicators, what's the CD4 count, what's the virus load, what else is wrong with the patient. And then there are issues about, are they ready to do this? Do they really understand? Are they going to be able to stick with it because they have to take this medicine every day, conceivably for the rest of their lives, which is a big commitment, and people do need to be in a place where they can do that, as in, you know, not shooting up methamphetamine or living in a box or whatever it is, if possible. And so these decisions are generally individualized, but these are the guidelines, current national guidelines in the US and in Europe for when to initiate therapy. And these are actually future guidelines. This is going to be published in the August edition of JAMA, you know, every other year, to coincide with the World AIDS Conference. There's a HIV, they call it theme issue of JAMA, where they just have HIV-related articles. And so this August is going to be one of those, and they're going to have new treatment guidelines, and this is what it's going to say. Not actually terribly different from the old ones, but so generally sick people need to be on medicine, anyone with less than 200 CD4 cells. This is still the gray zone, this 200 to 350, depending on the virus load and various other factors. Above 350, generally patients are observed. So that's kind of the ballpark. But again, this can be individualized based on the circumstances. I mentioned a lot of drugs that are in development. These are the ones that are licensed in the US for treatment of HIV infection. I won't read the list. These are the usual adult doses. And so, you know, very many considering how few we started with. This one is going away this year because nobody uses it anymore. It's too toxic. It's a TID regimen. And so this is going to be not manufactured after a few more months, so it'll disappear off the list. We have various combination pills which help in terms of, you know, compressing pill burden, making it simpler for patients to take their medicines. They're all made, the drugs that are currently combined are all made by the same company, but in a groundbreaking experiment, 2 companies have actually cooperated to produce a 3-in-1 pill. So this is 2 different companies have managed to reach some sort of licensing agreement that will be mutually beneficial to everybody, I hope. So later this year even, there's going to be, FTC is really the same as 3TC, they just tweaked it so they could make their own, but it's basically 3TC, tenofovir, and efavirenz in 1 pill. So 3 drugs, 1 pill, once a day. Also covers hepatitis B, so this is going to be good stuff. Somebody did tell me what the name of it was, and I've already forgotten. It was some fanciful name they've given it, but anyway. So this is going to be, I think, a real improvement in terms of keeping it simple for patients to do. These are the approved non-nucleoside reverse transcriptase inhibitors, and then protease inhibitors, numbering 8 so far. So a lot of options, almost too many really, it's kind of confusing. We do have, though, recommendations for which are sort of the best, the recommended regimens. which I'll get to in just a second. I forgot I had this in here. So I did want to talk about this phenomenon we call boosting, and I don't know if this term is familiar for protease inhibitors, but you'll see this a lot in the literature, use of boosted protease inhibitors. And essentially what this means is it exploiting drug-drug interaction. So most protease inhibitors are either inhibitors or inducers of this CYP3A4 P450 isozyme. So the P450 system, you know, in the liver metabolizes pretty much every other drug in the world. And these drugs inhibit the enzyme, which allows for increased concentration of other drugs. So this is a problem with, you know, dilantin and coumadin and rifampin and et cetera, but you can exploit it within this class and get away with smaller doses of drug, less frequent dosing intervals, and better outcome. So really what this means is using ritonavir, which is the most potent inhibitor of the enzyme, to boost levels of other protease inhibitors. And that's generally the way they're all used now. We very rarely use a protease inhibitor without some ritonavir. This is the entry inhibitor that I talked about. This is the very expensive and difficult drug. It has to be administered subcutaneously. It's a peptide like insulin. So they're working on an oral formulation, but it's not here yet. And essentially this just basically blocks attachment of the virus to the CD4 receptor. So because of cost and toxicity, it's reserved now for what we call salvage therapy or treatment of patients with drug resistance. It's not a first-line therapy. It also costs an absolute fortune, but it does have a role in terms of treating patients with drug resistance and limited options. So which are the best regimens to start with? So of the data that inform these decisions are from clinical trials, you know, how many pills people have to take, how often, how toxic, and how difficult they are to take. The usual regimen includes 2 nucleoside reverse transcriptase inhibitors and then either a non-nucleoside or PI. And there's really pluses and minuses to using both of these, with neither of them particularly being best. But that's your average 3-drug regimen, what the patients like to refer to as a cocktail. And again, this is going to be the August, you know, JAMA recommendations, not terribly different from the current ones. Efavirenz is the best NNRTI component, but there are some people who don't tolerate it very well. It has sort of neurologic side effects, at least initially, and it's potentially teratogenic, so not good for women with either pregnant or at what we call at risk for pregnancy, which I guess is sort of self-explanatory because of teratogenicity. So nevirapine is the alternate, and then the protease inhibitors, both of them with a small amount of ritonavir for this boosting, are lopinavir and atazanavir, with these as the alternates. So I don't think you need to try to remember this, but just so that you can have this available. These are the recommended nucleoside components. Again, these are available in combination pills. And this one is an alternate. It's not that it's not as good. This is Epsicom, abacavir, lamivudine. But the reason it's an alternate, according to the panel that write these recommendations, is because this one has activity against drug resistance when these ones fail, usually with a mutation at M184V. This drug will still work. And so it's kind of kept in reserve as a backup. It's not that it's not as good. So it's something to kind of keep for later on. So aside from chronic HIV disease, which is the main reason that we would prescribe these drugs, there are possibly other indications. Now, there's still debate about primary infection, this acute infectious flu-like illness people get when they're first diagnosed. Should you treat that? Nobody knows the answer. I think it's probably no, but being as it's so questionable, I don't think it's something, those of you that are here for the purposes of board exams won't get asked. And in clinical practice is something you probably have to refer to somebody or what have you. There's no clear guidelines about whether or not to treat this. Pregnancy is easy. Everyone should get offered therapy for pregnancy, and I have some slides about that. Post-exposure prophylaxis, nothing really new as far as that's concerned. A month's worth of 2 or 3 drug therapy works extremely well in reducing risk of occupational exposure, like from a needle stick, 80% reduction in risk. There is also non-occupational prophylaxis recommendations for people that have sexual exposure or drug-using exposure, much more controversial because of all the messages we've been having about abstinence, condoms, and prevention. People are generally comfortable with this in the setting of a sexual assault. ERs will offer it to people that have been raped. The other is a lot more questionable, but it clearly works, even though it's expensive and possibly dangerous. Just briefly about primary HIV disease. This is something some of you guys may have seen or will see in your practice. This is a guy that I saw with the rash, which doesn't look like much. It's just a viral exanthem. Very non-specific signs and symptoms. This is this acute seroconversion illness people get. If you look at this list, this could be anything. And I'm sure in winter months you have people stacked up in your waiting room who have many of these things. And so how do you sort out which ones just have some sort of viral infection and which ones have HIV infection, which of course it would be nice to diagnose, not necessarily for treatment of the patient particularly, but for the larger public health ramifications. And this syndrome resolves spontaneously, and then you may not see the patient again for 10 years, in which time all kinds of problems have happened. The best test for this is the virus load, HIV RNA PCR. It's expensive, but it works very well. And the only sort of guidance I can tell you to try to pick this up is obviously to kind of have it in the back of your mind. If you know someone has risk factors for HIV infection, that makes it much easier. Of course, in real life, that's not how the world works. You don't start taking sexual histories from everyone that you see that has a bit of a sore throat, necessarily. But if you just be aware that they may have risk factors. It tends to be a bit more prolonged than the typical sort of 3-day viral syndrome. This is something to think about for the patient who comes back on day 5, and they still have big lymph nodes, and they still have a fever, and you start thinking maybe they have mono or something. Just keep this in the back of your mind, too. Pregnancy. All pregnant women now should, of course, be offered HIV testing. There's actually a move afoot to make this what they call opt-out testing, whereas so rather than having to offer it to people, it would be part of a OB screen, and then patients would have to actually opt out of it. They'd have to do something to not get tested. And in fact, that's the sort of movement the CDC would like to see us making in lots of other areas of medicine too, where HIV testing isn't such a big hoop-de-doo with consent and all the drama. It's just a more routine thing. They think that would help find more of the thousands and thousands of people in this country that are undiagnosed. But anyway, certainly for pregnant women, and then be offered 3-drug therapy. Doesn't matter about CD4 and virus load, but those are sometimes helpful to know, can the treatment be stopped postpartum? If the mother doesn't need it for her own health, then you can stop it after the baby's born and just treat them during pregnancy. We talked about efavirenz being teratogenic, so not a good drug. These two together have caused lactic acidosis and fetal and maternal deaths and should not be used. Still debate about whether a C-section helps, depends a bit on the circumstances, and may be able to discontinue therapy. So this is a big success story. These are pediatric cases of HIV infection during the most recent year of data available, which is 2004, and of course you don't have the history to compare it with, but basically this is a huge improvement in dramatic reduction in perinatal HIV transmission with a combination of testing and use of antiviral therapy. So why doesn't this work better? Well, fact of it is, about half the number of patients that we give these 3-drug regimens to will so-called fail therapy, or therapy will fail the patient, I guess is a kinder way to say it. And this can be either because they get sick, their CD4 counts go badly, or generally it's virologic failure. Despite ostensibly being prescribed these drugs, they have detectable viremia, which over time leads to problems with drug resistance and immune decline. And the number of sort of 1, 2, 3, and 4 reasons for this is because people don't take their treatment. In the world of HIV treaters, we're very politically correct, and we don't talk about non-compliant patients. It's kind of a no-no because it's got a judgmental kind of quality to it. So you'll always see with reference to non-adherent patients, but it sort of means the same thing. They don't take their medicine. And the problem is, you know, there's several problems. We talked about the fact that many of them are, you know, living sort of marginal lives. They have competing subsistence needs. They're worrying about keeping a roof over their head and not getting beaten up and all the rest of it. That makes it hard. Taking medicine absolutely every day for the rest of your life is really difficult to do. And then you throw in the mental illness and substance abuse, and it's not hard to see why this happens. But the regimens for HIV disease are very unforgiving. You know, you miss a few doses and you're in trouble, which is a problem. So, of course, not liking the medicine and not just telling the doctor about it is another reason. People just sometimes just don't take it because it makes them feel bad. And then, of course, we have issues with people being resistant to the medicine at baseline, and then other more kind of pharmacokinetic type of reasons the medicines don't work very well. So the side effects I won't, again, go into a list of, but are not trivial, most of them. These are, you know, serious side effects that make people quite ill, and some of them can even be life-threatening. There's other lesser ones that are nausea and fatigue and headache and that kind of thing, but these are problems that really can cause difficulties for people. This rash, for example, that you get with nevirapine can be Stevens-Johnson, all your skin falls off and then you die kind of rash. You know, it's not just a trivial one. The hepatotoxicity, again, can be a problem. This is particularly the case for patients co-infected with hepatitis C, which many of them are. About a third of HIV-positive people typically in this country also have hepatitis C. Some have hepatitis B, some have all three, which is affectionately known as the trifecta in my world, but it's a horse racing joke, right? Okay. I didn't know. I had to have it explained to me. And then injection site reactions from the injectable attachment inhibitor. And again, mostly sort of below the diaphragm problems with protease inhibitors, lots of GI-related things, and again, hepatotoxicity. So what do you do about patients who have these sort of side effects? Well, if they're not really that bad, some of them may be self-limiting, and you could try getting them through with symptomatic therapy, you know, Imodium, Compazine, sort of general kind of support, and sometimes they will go away, or at least patients stop complaining so much. I'm not sure quite exactly which way it goes. If you can identify a culprit drug and the patient's really having trouble with, and they're not, you know, this sort of so-called treating through it or just putting up with it isn't working, then you can just switch out whatever the offending agent is and keep on going. But generally speaking, for the severe toxicities, much as the ones on the previous slide, you know, the pancreatitis and all that type of thing, you just have to stop everything, wait for it to get better, and then regroup with a hopefully less toxic regimen. I do want to talk just briefly about metabolic complications, which are were kind of a hot topic for the last few years. I think over time this is going to get less of a problem because the newer agents that are now coming out are much less likely to do it, but there are a lot of prevalent cases still out there, and certainly not over yet, that long-term use of combination antiviral therapy causes abnormalities in both glucose and fat metabolism in ways that we are poorly understood, and even whether they're all connected, probably yes or not. And this includes both the nucleoside analogs and protease inhibitors. The non-nucleosides do pretty well in terms of this particular issue, although there is some hypercholesterolemia with efavirenz. But generally speaking, the mitochondrial toxicity, fat wasting, and increase in triglycerides is associated with long-term use of nucleoside analogs, and then insulin resistance and high cholesterol with PIs. But of course, most people take these all together, so then they get a kind of a mixed picture. These are the fat redistribution syndromes. Often you'll see this referred to as lipodystrophy. The sort of current thinking is that really there are different elements to this, and so we try to be more specific and talk about actual fat loss, lipoatrophy, which is typically in the limbs, as is illustrated by this patient. And this is the most common manifestation. Many patients will also have fat accumulation, usually in the middle. And this is not just abdominal wall fat, this is visceral fat. So the fat gets in the liver, which of course makes the liver unhappy, and other organs. Facial wasting is not so much, of course, a big medical problem. No one's going to die of this, but it's a big concern for the patients because nobody likes to start sort of looking different. It's not attractive. It's potentially stigmatizing now because you can tell by looking at someone that they have AIDS and they're on medicine, which traditionally, of course, you couldn't always, particularly earlier stages of diseases. And so why the drugs, preferentially will impact certain areas of fat, we really don't understand. Why this and not another. Fat accumulation as a buffalo hump or dorsocervical fat pad is rare, but again, unpopular. And then breast enlargement. This occurs in men and women, but of course the men are the ones who are likely to complain more, dislike it more. Although it's a nuisance for women too in some cases. So these are the manifestations of chronic fat redistribution that we see on medicine. So big impact on quality of life and, of course, indirectly on adherence. This is a reason people don't want to take the medicine and may go off it because of these changes. There's no sort of easy diagnostic test, whether a CT is better than a DEXA, or nobody exactly knows. Again, for clinical management, that's not a huge problem. But as I say, over time, we're going to see less of this because the drugs that do it the worst are sort of the more old-fashioned type of antivirals that we don't use as much, and the currently recommended ones are going to cause much less incidence. Complicated pathogenesis, treatment options very limited, very modest improvement when switching off some of the so-called older nucleosides, the thymidine analogs, but it's very modest, not huge changes, and takes time to develop. Lactic acidosis, hyperlactatemia, again, a problem we're going to see much less of. It's already not very common, but this is caused by mitochondrial toxicity from nucleoside reverse transcriptase inhibitors. So they deplete mitochondrial DNA by inhibiting polymerase gamma. But anyway, they actually do damage mitochondria, which can then turn people into anaerobic type metabolism and frank lactic acidosis, although that's rare. This is the order in which the drugs do it. So these newer ones are much less toxic to mitochondria. These are the older ones that are. This is one of the reasons DDC won't be made anymore. The hyperlactatemia has rather non-specific symptoms, so it's something to think about when you see patients in your practice. Of course, some of these are hard to tease out from side effects of the medicine or just being ill, but it is something to think about, checking a lactate level. Fortunately, there is no asymptomatic lactate problem. You don't have to do it routinely, and the severe life-threatening kind is very rare. I can't remember, it's been maybe 5 years since I've seen one, something like that, even though we used to see them fairly often. Glucose metabolism, generally associated with protease inhibitor use, the spectrum from insulin resistance to frank diabetes. Of course, the management, at least we have options here, which are identical to the ones they use in endocrine clinics, diabetic doctors, except having to be careful about metformin because, of course, that causes lactic acidosis too. Again, something we're probably going to see less of moving forwards, but still a problem. And, insulin resistance is not good for people. Dyslipidemia, we see a mixed picture, usually in HIV-infected patients on therapy, both with high cholesterol and high triglycerides. So generally, they need combination therapy. We use these, what is this, National Cholesterol Education Program, I think it is. This is sort of the standard guidelines for what your LDL is supposed to be. We use the same guidelines. In terms of doing that, we try to get people to diet and exercise and stop smoking, which is a big problem in HIV infection, actually, because a lot of people smoke. And oftentimes it seems, they've given up sex, they've given up drugs, and you cannot get them to give up cigarettes. I mean, it's just something they absolutely will hang on to and die of a heart attack rather than stop, so that's a problem. And the other issue for this is that the statins are all metabolized through this same P450 mechanism, and so you do have to be careful about using them with patients on therapy, which of course they all are. So atorvastatin is our drug of choice. Pravastatin, Pravachol. Atorvastatin is Lipitor is the next one, and the rest you have to be very careful about. Some of them you shouldn't really use at all, but you can usually get, with one, either Pravastatin or atorvastatin, you can get where you want to be. Tricor, Zetia, all those things, fish oil, not a problem. And so is this going to translate into increased heart attacks and strokes, premature cardiovascular disease in people with HIV infection? And nobody knows quite yet, but the initial results of observational studies are concerning. So this is a large collaborative study. Can't remember what DAD stands for, sorry. It's a European and Australian and US study looking at a big cohort of patients over time, and this is duration of antiviral therapy use. You see it often referred to as HAART, highly active antiretroviral therapy. It's not really a term I like very much, but you'll see it used a lot. And risk of this is actual myocardial infarction in patients over years, and it's clearly increased with increased exposure to drugs, so about a 3-fold increase in risk compared to age-matched control. So it does look as if there is going to be a problem with heart attacks and strokes occurring earlier than expected. Bone disease is the least well understood metabolic complication. This is a patient of mine, a young man who tripped while vacuuming and put his hand out and fractured his radius and turned out to have severe osteoporosis. It's unclear as to exactly why this happens, again, seeming to be associated with chronic protease inhibitor exposure. So again, there's a spectrum, milder bone loss to frank osteoporosis with increased fracture risk. We also see avascular necrosis quite often, usually of the hip, sometimes shoulders too. This seems to be clearly associated with steroid use. And talking about corticosteroids, so this is, the people that come in with pneumocystis pneumonia and get steroids and later on maybe turn up with avascular necrosis of the hips. Some patients even as little as a dose pack, Medrol dose pack for poison ivy or something. So we have become more cautious now about prescribing corticosteroids in people with HIV disease, obviously if they're really necessary. But as we all know, sometimes it's a gray area. The traditional risk factors for osteoporosis are also prevalent in the HIV-infected population in terms of smoking too much, not eating well, and then there are, the hormone issues, particularly for women. So at the moment, the guidelines are to sort of think about this, particularly if you see a non-traumatic fracture or fracture with minimal trauma, think about bone density screening, but it's not something that's routinely recommended for all patients. Okay, treatment failure. What to do when your best isn't good enough and the therapy fails. So traditionally, this is, again, success is defined as less than 50 copies. Failure is more than 50. How much more than 50 is debatable. But essentially, if they're on medicine, they're supposed to have virus below the limit of detection, and anything else is theoretically a failure to varying degrees. So first of all, you have to do this so-called adherence assessment, which is sort of shining a bright light in their eyes and finding out if they're really taking their medicine. Well, there's ways of approaching this. We call the pharmacy a lot to find out when they're picking up refills, to try to find out if it's a money thing or a side effect thing or whether they're really depressed. And there are simple screening tools for that can help. So there are some things you can do to try to sort of see if that's really the problem. And then the other tool we have is resistance testing, either a genotype or phenotype testing. And this is often helpful to differentiate whether the patient's failing because the virus is resistant or just because they don't take their medicine. So if you do a resistance test and there's no resistance, it just basically means, if they took the drugs, they would work, they must not be taking them. Of course, not taking them half the time will promote the development of resistance. So these things are definitely interlinked, but you do have to try to sort out the contribution between patients just not taking it and what can we do about that, and then the viral resistance. This is a study that I did some years ago looking at Adherence as measured by these little electronic bottle top MEMS caps, and how it impacted it. I won't go into detail, but if you just look at this middle bar here, these are patients who took 80 to 90% of prescribed doses of medicine over a year, which really is not bad. You know, if you think about your patients with hypertension and everything else, that's not a bad metric. They have a 50-50 chance of getting virologic failure. So that's what I mean by this is very unforgiving. You can't miss many doses and you're in trouble, which is a shame, but that's the way it is for now. So these are obviously the typical kind of things that will cause patients to be less likely to take their medicine, you know, than drinking, using drugs, don't really understand the whole virus idea, have troubles getting here, are mistrustful of the establishment and doctors and everything else. So this is not unique to HIV infection, but it's a big problem. This is an example of a resistance test. This is a so-called phenotype test. I don't know how hard that is to see, but essentially it's like a sort of antibiogram that we can get now. It's an expensive test, but very helpful. Lists the drugs down here, and then compared to a reference strain in the laboratory, how much more or less susceptible the patient's virus is to the reference strain, and then we'll give you kind of a snapshot of, you know, which drugs might work better for a subsequent regimen. So there's also a so-called genotype testing, which looks for specific mutations. Which test is better is not known. This is more expensive and takes longer, but maybe gives you a little more information. So it's sort of a toss-up. The improvements in outcome are not dramatic, but they're definitely there, modestly improving outcome. It's really, when you have a patient who's on treatment and failing, the general guidelines for doing this testing is they have to be actually taking the medicines when you do the test, and they have to have a virus load of at least 500, probably more like 1,000, to get an accurate reading on this particular test. They both require some interpretation, which may require a consultation from somebody. There's also some websites and internet resources that you can use. We've been talking about looking at drug levels to see if that's going to help us too. We haven't really got very far with that. It's a tool we use in general ID a lot. You know, you look at the resistance of the bug, and then you monitor levels of vanco or whatever it is. Really hasn't taken on in terms of monitoring of HIV disease, and still something that's being talked about, but not going anywhere in a hurry. They have short half-lives, so really when you measure a drug level, you're just seeing, did the patient take their medicine that morning? You know, and most sensible people, if they're going to the doctor, they actually would think to do it that day, so probably not that helpful. What to change to, or when to change. Again, no consensus. Do you switch as soon as things go bad? Do you wait for a few weeks, months? Nobody's quite sure about that. There are pluses and minuses both ways. The general consensus guidelines are that, if possible, you replace the whole regimen if you can, if the patient has resistance. Don't just put a single drug into a failing regimen. It's kind of the TB paradigm. If you have a whole new group of drugs available based on the patient's treatment history and prior resistance, then go ahead and change all of them. Now, you can't go backwards. That's part of the problem. And recycle older drugs that they failed on is unlikely to work. Sometimes you have to if there's no other options, but typically you are looking for newer drugs that their virus has not seen. So ideally, you want a protease inhibitor the virus is not resistant to, and if you can get access to one of these newer agents with a different mechanism, that's all good too. There was a little bit of a phase we went through of doing so-called structured treatment interruptions. You know, people would go off their medicine, the virus would lose all the mutations, and then you'd start again with something else. That's off the table. It didn't work. Don't do that anymore. They're better off on medicine, even if it's not working very well, than interrupting. So going off medicine, generally a bad idea. What's coming new in terms of availability for people with drug resistance or treatment failure? This drug's already just been approved, Tipranavir, again used with ritonavir. Good activity against multi-drug resistant virus. Problems are it's really quite hepatotoxic. We've had a lot of trouble, especially in our patients with hepatitis C. This livers just really don't do well with this. And it's also It has a bit of sulfur in it, so all the Bactrim allergic people get a rash on this that doesn't go away. This drug is coming this year, later on this year, again, a new protease inhibitor. Actually, more tolerable side effects and probably similar activity against drug resistance. So this will be a nice addition. And there's others in the pipeline, but this is the sort of 06 batch of new drugs to expect. And then very briefly, prevention of opportunistic infections, not something to be overlooked, nothing really new and exciting to say, though. Pneumocystis, it's not called Carinii anymore. I don't know if that's exciting, but it's been reclassified, and it's now called Pneumocystis jirovecii pneumonia. It was originally misclassified, and so they've gone back and done that. But we just, essentially, if you call it Pneumocystis pneumonia, it's easier. CD4 count of less than 200, and Mycobacterium avium complex prophylaxis is a CD4 count less than 50. That's not different. These are the preferred drugs in order of how useful they are. And again, for Mycobacterium avium, the macrolides, either Clothro or Zithro, are equally efficacious. Most people like azithromycin because of the once-a-week dosing. Rifabutin works well, but again, it's a rifampicin, and so there's problems with drug interactions. There's no guidelines for HIV for fungal or CMV chemoprophylaxis. That's something you kind of watch for. And a lot of times for toxoprophylaxis, some of the drugs for pneumocystis work well there too. So the good news is that access to new medicines has dramatically decreased both the incidence of AIDS and the death rate from AIDS in countries where the drugs are available. Again, remember that's only 5% of the affected population, but still it works well here. And then just for reference, this is the home of the federal treatment guidelines, which are listed on here, just so that you can have that in your file.
Patients, do you see resistance to therapy in patients like, for example, that have Crohn's disease, hepatitis B, hepatitis C, chronic diseases plus HIV and AIDS? Do you see resistance in the therapy with medication? Because I have a patient in Fremont that has
all those things,
and has Crohn's. Yeah.
Yeah, Crohn's disease is not something that I don't think is associated with HIV infection particularly, but any kind of digestive tract disease I think is potentially a problem, because you always worry about, are the drugs getting absorbed properly in people that have dysfunctional GI tracts, and nobody really knows the answer to that, but it's quite likely that they're not. And then, so what do you do about it? Do you give them more or what have you? Viral hepatitis doesn't necessarily impact HIV drug resistance. I mean, there's no direct correlation between the fact that someone has viral hepatitis and do they then have HIV drug resistance. Obviously, they may be associated with substance abuse or something that would contribute, but certainly with bowel diseases of all kinds, we've had problems in our clinic, even though, now it's this, what do they call that, bariatric surgery, the stomach stapling is very popular anyway for people that have trouble with obesity, and we have a few patients who've had that done, and things go through their GI tracts incredibly quickly, including, I think, their medicine, and so then that's kind of an issue too. So anything like that, I think, can impact.
And if you have a patient with primary HIV disease with these non-specific symptoms, which of the one do you do? The P24 or the HIV RNA?
I would do the RNA. It's more expensive, but you'll get the answer you want. So, the question is referring to injectable, I don't know what it's, polylactic acid. I'm not even sure what it is. So, I'm sorry? It's called Sculptura, is the brand name.
I don't
Something
think it's
that you
silicone.
inject into the face to fill the defects, some sort of like,
It's for lipodystrophy, yeah. It's a special
so
thing.
Plastic surgeons do it. They do some sort of stuff. The brand name is Sculptura, and it's a polylactic acid, although I'm not sure what that means. It's something that you get at Home Depot, to fill in holes. But anyway, so you have to have multiple injections to fill in this fissures that people get in their faces, and it actually works quite well, although like a lot of things, it's sort of like the Botox thing. I think you have to go and have touch-ups later on and so on, because it's expensive. We've had very bad luck getting insurance to pay for it, because it's really a cosmetic issue, which it is. So we've had bad luck. Some patients of mine have actually gone to Canada, because it's cheaper there. Well, that's a kind of a broad question about what to do about HIV in Africa. Finally, I think the world has woken up and sort of noticed there are multiple initiatives going on at the same time in terms of making access to, giving access to antiretroviral therapies. So the WHO has spearheaded the major one. They had this 3x5 campaign, I don't know if that was familiar to you or not, where they put a lot of resources into getting 3 million people on antiretroviral therapy in sub-Saharan Africa by the end of 2005. And so sadly, they fell far short. They ran into way more infrastructure problems than they ever anticipated, and so they didn't even get half of them on. But they haven't given up. They've called it something else now. So that's you know, the forefront of it. There's Gates Foundation money going into it, World Bank, and so forth. So most but not all African countries now have some access to limited antiretroviral therapies. Nothing like the menu that we see here. And sadly, they're getting these older drugs, you know, that we don't want anymore. And so the ones that are more toxic, that's what's available, but it's better than nothing. There have been breakthroughs in terms of ability of African countries to produce generics. You know, that was a big fight, for example, with Glaxo Wellcome, because these drugs are still patented, and so India and Africa just wanted to make them, and that's now actually happening. So that's something. But just the sort of the sheer scope of it is somewhat overwhelming, and the doctors that I talk to there are really you know, struggling to keep their heads above water. But it's progress. It's just slow, and it's way too late. You know, it's really sort of I suppose a global shame that no one did anything about this sooner. The questioner was just saying he works with medical missionaries in Dominican Republic, if I got this correct, and they have literally no access to antiretroviral therapy at all. None. So, and South America is kind of patchy. You know, Brazil is actually a model. They make it universal access, and they make their own drugs, and they've done very well. But many other South and Central American countries are also way behind. So, yes.
Is there any work going on with a vaccine at all?
Oh, yes, good question. I didn't mention vaccines. The preventive HIV vaccine, I did have a slide about that, but not in the talk today. It is being worked on, yes. There's a lot of resources going into this, a lot of NIH-funded research money, and not enough, actually, pharmaceutical money. Very few of them are interested in vaccine development. And that's not just this vaccine, any of them. You know, it's really hard to get drug companies interested in putting money into vaccine development. And I personally blame lawyers. I don't know about you, but I think that's a big part of it. It's a huge problem. You know, there's all kinds of factors that impede vaccine development. There's the problem of no natural immunity, you know, the fact that nobody gets HIV and gets better, and then they're immune, and you can look at, is that antibody, is it cellular, what is that, like with measles, say. There's no good animal model. You can infect animals where they don't get AIDS, even chimpanzees, the closest species to us. There is this viral diversity problem, you know, with these subtypes. So a vaccine that would work in the US wouldn't necessarily work in Africa. And then there's the problem of, you know, the danger of using a live attenuated virus vaccine, which probably would work the best. So measles is a good analogy here too. You know, some children, of course, will get a sort of measles-like illness from the vaccine, which is really not that big of a problem. Getting HIV is sort of like getting pregnant. You have it or you don't. And so if you give it to people with the vaccine, it's a problem. So those are some of the issues, but there's nothing on the horizon. I don't know if there'll be anything, you know, in our lifetime. I hope so. My feeling is if we ever do get one, it won't be a great vaccine. It'll be one of those where you keep having to have boosters and you only get partial immunity, but maybe something, but nothing anytime soon. It's not going well. Yeah, questions about universal testing, an excellent question. There is movement towards that. And the main obstacle is political, really. This is a very political disease. And so it's very hotly debated as who you can test for HIV and who you can't, and whether people can, you know, be tested without consent. And there's a lot of hoop-de-doo about that because of the potential consequences of finding out you have it in terms of, you know, aside from the health things, the stigma and you lose your insurance and et cetera, et cetera. So those are the main obstacles, but there's definitely movement in that direction. And the way they refer to it is to make it opt-out testing, where it's a sort of a part of a routine battery for all kinds of things, and if you don't want it, you have to specifically opt out. And I think that's happening. That's going to be happening within the next few years, so for sure, it's getting better.